Hello. So this is the third part of acid reflux. So first part I have given you a small introduction and the importance of presence of acid and the aggravating factors for acid reflux. The second part I have covered the common patient complaints and the examination finding. And the third part I will tell you mainly about the necessary related investigation and what all will be the findings. And plus please do watch the fourth one, the most important one, where I will deal with the treatment part. So the investigation to start with, we will do a laryngoscopy. Laryngoscopy, here we pass in an endoscope through the nasal cavity, it goes way behind the nose and behind the tongue to examine the part behind the tongue too. That is from the nasopharynx up to the voice box. And if the patient has got acidity, the common finding will be there will be redness covering the whole area. And the redness, the severity, depending upon the severity of the condition, the redness also may change. So this one doesn't need much of preparation and it hardly takes 5 minutes for the whole procedure. Now, we can do a barium esophagogram and a barium meal too, where we will send the patient to the radiology department, and with due preparation they will ask you to drink barium in a liquid form, and they will expose you to fluoroscopy. So in that, what it will pick up is, it can pick up small ulcers which may be present in the esophagus for the food pipe, or small ulcer which may be present in the stomach. And sometimes what happens is, because of gastroesophageal reflux disease which is persistent for a long time, this can lead to stricture, means the part of the stomach or esophagus, it can become narrow. Even that can be picked up with this barium esophagogram. So after this investigation and giving a trial run of medication, suppose the patient has not improved, we will refer the patient to a gastroenterologist. So they will do a gastroscopy, where it's a daycare procedure, and they'll give a slight sedative. They'll pass in the gastroscope through the oral cavity to the mouth. It goes down the food pipe. It examines the food pipe, where we want to have a look of the covering of the food pipe, whether it is red or not, any infection is there or not, any ulcer, any growth is there or not, and it is passed into the stomach, where we look for the same findings. In case we find any ulcer or any growth, we will take a biopsy, and extra to that, we like to do a clot test, CLO clot test. So both this will be done with the help of gastroscopy. So the clot test, it will pick up whether the patient has got H. pylori or not. Why do you want to see that? Here, H. pylori, it's a type of bacteria whose presence in the stomach can induce and aggravate acidity, which can in turn lead to gastric reflux. So if suppose the H. pylori test comes positive, then we have a specific treatment for that, and the patient will get cured also. Now, the next step, in spite of all this, the patient is not becoming okay, and we want to know whether the diagnosis is correct and the severity of the gastroesophageal reflux or severity of the acidity, we will go ahead and do a 24 hours pH monitoring. So as you see in this picture, here we have a small gadget monitoring device, and there is a small tube which passes from the nasal cavity into the esophagus, and the probe which is kept just above at the lower end of the esophagus. And after a time period of 24 hours, we will monitor, we will see how much is what is the severity of the acidity. So in some patients, we will like to know the resting pressure of the lower esophageal sphincter. For that, we will do a esophageal manometry. Now, even this urea breath test can be of help. Here what we do is, we ask the patient to drink a fluid which contains urea, and if suppose the patient has got acidity because of H. pylori, This urea which reacts in the stomach and it releases carbon dioxide which can be picked up in the exhaled air. And we can come to know that the presence of H. pylori and the patient is symptomatic, so we can presume the patient has got acidity. And very rarely we will go ahead and do a gastrin test. If it is very high, it indicates that the patient either she has got Zollinger-Ellison syndrome, or we can have a monitoring of the common proton pump inhibitor which the patient is taking, and the gastric test is positive even in a condition called chronic atrophic gastritis 2. So these are the common investigations which are usually done in a patient. So all these tests are not done in all the patients. It depends upon the severity of the condition. So which are the patients we need to refer to a gastroenterologist? So those patients who have failed the maximum medical treatment, we need to refer them to gastroenterologists so that they can go ahead and do a gastroscopy. Not only those patients, in those patients who have acidity, and along with the common complaints, they have any one of these like weight loss, they have anemia and persistent swallowing difficulty, and sometimes they complain of blood in the stool too, and persistent voice change, which is not related much to the local condition in the voice box. And some patients may have repeated chest infection, or if they are asthmatic or they have bronchial asthma, they have repeated attacks of breathing difficulty. So these patients, we need to know the severity of the condition, severity of gastritis, and as soon as we cover and we help them in reducing the acid level, take care of the acidity, the other conditions may come back to normal. So if suppose we have come to a diagnosis of acidity and it is severe, and suppose we neglect them, what will happen? In these patients, it may lead to esophageal, the foot pipe ulcerations. These ulcers can bleed and sometimes rarely it can perforate. And long-term ulcers, whether it's in the foot pipe or in the stomach, it can lead to the change in the shape of the structure. It may contract, it can lead to strictures. And it can lead to infection of the esophagus also. And one thing which I already mentioned, the ulcer in the stomach, in the lower end of the foot pipe, it can get converted into malignancy. Likewise, if there is a severe severe acidity in the voice box, even that can lead to malignancy of the voice box. Other complications are, it can keep on precipitating asthmatic breathing difficulty attacks. And small amount of aspiration will lead to chronic cough, chronic dry cough. These are the common complications which I have mentioned. Now, as I have mentioned, the most common presentation will be, heartburn. They say they have retrosternal burning sensation, chest discomfort. So such a patient, when they come to us, the first thing, the dangerous thing which strikes in a mind is whether this patient is this acidity or is it MI, myocardial infarction related to the heart. So we will examine your pulse rate and the blood pressure and take in a detailed history, and if we feel that this may be related to the heart, we will ask for a ECG, echocardiogram, and at the same time we would like to do a blood test, troponin 1, and which has to be repeated after 1 hour. When all these are negative, it means it is not myocardial infarction, not related to heart, so it is related to acidity. So we will give a shot of proton pump inhibitor and we will prescribe you the medication for a few days. So one of the most important differential diagnosis being myocardial infarction. So here I have covered mainly the most important related investigations, the common complication if you neglect, and the differential diagnosis. So please do watch the 4th video where I will deal with the treatment. Thank you so much.